So, my name is Savika. I'm one of the fourth year medical students, and I've had the pleasure of actually giving you this talk on cardiovascular pathology. In fact, I don't want it to be a talk. I want it to be as interactive as possible and best for your learning. Um, so if you have any questions at any point or you want to get involved in the questions that we'll do, feel free to, and I'll try and keep this as interactive as possible. So. First of all, if you guys could just join the Socrative room, just go to socrative.com and just type in this code and it should let you into the room. And there should already be a question on there asking which of these kind of subtopics you find the most difficult, and we'll go through which ones you would want to go through first, because there's quite a lot of content to get through. And I don't know if we can condense it all into an hour, so I want to get through what's most beneficial for you guys. It's got 2 people on there, so I know it's working. So if we can try and get logged on and put in your options on there. Okay, so far, cardiac output is in the lead, followed by blood pressure, circulation, and electrical activity. So it seems like pharmacology is all right for you guys. Oh, okay. So I'll start off with cardiac output because that's what you guys are finding most difficult. So just bear with me whilst I go through all these slides. Okay, so cardiac output. So this is I can understand why it's quite a difficult topic because there's so much going on, and it's not one of those easy things to get your head around. So I like this nice summary diagram, even though there's a lot of stuff going on there. It kind of summarizes everything you need to know. So these different curves, first of all, looking at the pressure, so on the y-axis, in the different compartments of the heart. So you've got different chambers. So you've got your atrial pressure, your ventricular pressure, but also looking at the aortic pressure because that's where eventually all of the blood is going to supply the rest of the body. So looking at the changes in pressure throughout the cardiac cycle is going to explain what's going on, what valves are closing, and why there's a certain change in pressure and what the function of that is. So first of all, it's important that you understand how pressure affects the valve opening and closing. So valves are almost like a one-way gate. If the pressure above the valve is greater than that below, the valve will open, and if the opposite is true, so pressure greater at the bottom compared to the top, the valve will close. So it's a one-way system, allowing blood to flow through or not, depending on which part of the cycle you are in. So wherever you see the intersection between 2 lines or curves on the graph, that is indicating a point where the pressure of one chamber is greater than the pressure of the other chamber, and that's where the valve will be opening or closing. So you can see there's 4 intersection points, as so, and these are where your mitral valve, so your the valve in your left ventricle, is going to be opening, or your aortic valve is going to be opening or closing. Okay. Just think about what pressure is greater at that point. So in this case, the ventricular pressure is going to be greater than the atrial pressure, hence why the valve is closing. And then it reopens when sorry, my mouse has disappeared. It reopens when the atrial pressure is now greater than the ventricle. And these 2, closing and opening, will correspond to, sorry, the closing will be corresponding to the heart sounds. So the first heart sound, as you see here, will correspond to the mitral valve closing, okay? Or i.e. the atrioventricular valves, because you've got both sides there. And the second heart sound will be when your aortic/pulmonary valves are closing. And so that's that heart sound there. Okay. Looking at the ECG, you should be able to kind of work everything out and put it together, because the P waves here represent atrial contraction. So you can see the atrial pressure goes up slightly. The QRS complex is corresponding to the contraction of your ventricles. So you can see the ventricular pressure massively increases. And this T wave here corresponds to the ventricular relaxation. So the pressure in the ventricles should drop significantly. Okay, as long as you understand those basic components of the cardiac cycle, you should be able to work out what each of these valves are doing, what the chambers are doing, and how it corresponds to the heart sounds. Okay, in your syllabus, you also have the mention of heart sound 3 and heart sound 4. So heart sound 3 is something called a ventricular gallop, and it's often found in patients where they have compliant hearts. So it's actually a healthy heart that is working better than the general public. So you might see these in younger patients, athletes, and pregnant women, or you can also find it abnormally in people with systolic heart failure, because remember, it's to do with the ventricles. So it's during systole, when the heart is contracting, that you get this ventricular gallop in heart failure or left ventricular hypertrophy, where the left side of your heart is a bit bigger than usual. Okay. Heart sound 4 is mainly found in non-compliant hearts, so more diseased or pathological hearts, and it's called the atrial gallop. So it's to do with the resting phase of the heart, hence why it's found in diastolic heart failure or ischemia, where the heart is deprived of oxygen. Any questions so far? Just you can pop it in the chat and I'll have a look through and answer those for you. So looking at the volume pressure curve, we're going to correspond this to the action potential of the ventricles as well. So most of you were confident with the cardiac action potential, or like the electrophysiology. So I will do a brief recap whilst explaining this volume pressure curve. So the volume pressure curve, as it says in the name, is comparing the volume in the ventricles with the pressure, especially the left ventricle. And what it's showing is showing how the different phases and how the volume changes in those different phases of your cardiac action potential. So 4 is kind of resting membrane potential. 0 is your rapid depolarization. Then you've got your phase 1, the plateau phase into phase 2, and then repolarization during phase 3 and back to rest at 4. So with your volume in the ventricles during phase 1, where you've just depolarized and you're entering into your plateau phase, that is your diastolic filling phase, where the heart is not contracting, but is passively filling with blood. Okay, and only until you get to a certain volume or a certain part of that phase is when phase 2 kicks in, which is your plateau phase, where you've got isovolumic contraction. What that means is you've got the same volume of blood in the ventricle, but you're contracting at that point, and so your pressure will increase. So iso means same volume contraction. So you can see the volume is stuck at this point here, but the pressure is increasing massively because of the actual contraction during phase 2. And then in phase 3, you've got the ejection of your blood out of the ventricles into the aorta or the pulmonary artery. And finally, you have phase 4, which is your relaxation phase. You're going back to baseline. So this is where you've got isovolumic, because it's the same volume again, but now it's relaxing, so the pressure in your ventricle should come down. So it's nice little, almost like a rectangle shape, showing how the pressure and volume are related throughout the phases of the cardiac action potential. And these circles here represent which valves are open and which ones are closed. So mitral is open at this point, and then it closes here. Aortic opens and aortic closes. So you can see again, it's related to the pressure in each chamber and how or which direction the blood is flowing. So the fancy equations that you might have to remember, main one is cardiac output equals the stroke volume in the heart times the heart rate. So stroke volume is the amount of blood that you're essentially pumping out to your organs. So it's the end diastolic volume, the volume left in your heart at the end of the resting phase, minus the end systolic volume, so the volume left in your ventricles after the heart has pumped the blood away into your aorta and pulmonary artery, the aorta. So that is essentially how much blood is the heart forcing out through the vessels. And you multiply that by the heart rate, so the beats per minute, and that should give you your total cardiac output. In a healthy individual, that should be about 5 liters. So that's a kind of a figure that you should remember. Now, the cardiac output has several factors that can be impacting or influencing it. Main ones are innervation, so the neural supply to the heart. It's got both the parasympathetic and the sympathetic innervation, which are essentially branches of the autonomic nervous system, because the heartbeat and heart contraction is kind of an automatic function. We don't have voluntary control over it. So there are 2 nodes in the heart that you might know of, so the sinoatrial node and the atrioventricular node. So the parasympathetic can have influence on both of these, whereas the sympathetic is mainly the SAN and AVN, but also can supply the ventricles as well. So let's look at the different components and how different things could actually be impacting cardiac output. One of the other equations that you might be required to know is this one here, where you've got cardiac output equals VO2, so the volume of oxygen, divided by the concentration of oxygen in your arterioles versus the venules, or the venous end. And essentially, this is what it's trying to portray is that oxygen consumption, so how much oxygen you're using, is a product of your cardiac output, but also the difference in your arterial versus venous circulation. So that's essentially what this equation is trying to portray here, and that is called the Fick principle. So if you get a question with, your cardiac output, or they've given you concentrations of oxygen in your arterial end versus the venous end, they might get you to calculate oxygen consumption or cardiac output from that information. So this is where you'd use that equation. So moving on to the Frank-Starling law, and this was something that I found really difficult to understand. So I'll focus a bit more time on this. So essentially what the Frank-Starling law is telling us is that your heart is going to be matching venous return, so how much blood is coming back to your heart, to the cardiac output. So how much blood you are putting out overall should match how much blood you're getting back into the heart. Now, we mentioned before there were some neural component to the regulation of cardiac output, but also some hormonal influences. But Frank-Starling law is telling us that there's an element that's independent of neural and hormonal input, and that is your Frank-Starling law. So there are 2 experiments which, if you're writing an essay on, would be good to include. So Otto Frank's experiment, essentially what he did was he ligated the aorta of isolated frog hearts. So you're using a heart that's been taken out of a frog, and they kind of close the aorta so that when you have the contractions, they are purely isovolumetric. So the volume shouldn't be changing, but the pressure should be, because you've blocked off the aorta. When you've got an increased volume of diastolic fluid, so that's your preload, right? The amount of volume that you have before the heart or before you're contracting, an increased preload essentially created a greater pressure during systole. So when it's kind of like, if you think about, if you give yourself more energy, i.e. the preload, what you're putting out is going to match that. So you get an increased pressure with systole. And so they concluded that the energy of contraction of your intact heart will increase with diastolic stretch, because the more fluid you're pumping into the heart, the more you're stretching those chambers, and consequently, there's a greater recoil when the heart relaxes. Okay, it's kind of like an elastic band. If you pull it more and more and more, the overall force when you let go is going to be much greater than if you just pulled it a little bit. Now, Ernest Starling's experiment kind of added on to this, where he created a more physiological setup, because this wasn't very, very close to how physiology works in a human, for example, and that's a limitation you can actually mention about this to get more marks. So Ernest Starling created a more physiological setup using isolated dog hearts instead. So you can already see the difference, the frog versus dogs. But he also used the lungs as well, which is perfused with oxygenated blood. And that's going to mimic the venous reservoir, okay? They also used a variable resistor, and you don't need to know like the physics behind this or anything, but it was mainly used to maintain the aortic pressure, okay? And so when you increased the reservoir height in the venous system, that's your central venous pressure, this led to an increase in the right ventricular end diastolic pressure, okay? And this led to an increase in the right ventricle stroke volume, so the amount of blood that the right ventricle was pumping out to the lungs. As a consequence, the blood that was returning back to your heart by the left side increased, so increased left ventricular end diastolic pressure, and that increased your left ventricular stroke volume. Okay, so the amount of blood that was ejected from the left ventricles and into the aortic circulation. Now remember, the equation for for cardiac output included both heart rate and stroke volume. And if you increase the stroke volume, you're going to increase your cardiac output. And that's what they concluded here, saying that the cardiac output from both ventricles increases with increased central venous pressure, i.e. increased reservoir height. Your central venous pressure will eventually lead to a greater cardiac output. Okay, so these are two experiments that would be good to include in your essays. And looking at a diagrammatic version of the Frank-Starling law, what they're showing here is the amount of stretch in your ventricles. Okay, so it's the amount of stretch at the end of diastole, because that's essentially when you have just relaxed and you're almost going to contract the heart. And they're showing that with greater venous return, so the amount of blood coming back to the heart, you get a greater stroke volume, because greater venous return, you get more stretch, so you're going towards this direction. And you can see if we take the normal curve here, when you move further this way, you get a further increase in stroke volume. So this is shown diagrammatically, and that's due to the stretching. Now, looking at different conditions, because this is where the pathology side comes into, when you've got a normal heart that is kind of working a bit better than the general public, you have essentially a more accentuated Frank-Starling curve. So, i.e., even a small increase in your myocardial muscle stretch, you get a massive increase in your stroke volume compared to a normal person. It can become pathological in heart failure, because now your contractility is a little less because your heart is struggling, and so you need a lot more stretch to produce the same increase in stroke volume. Okay, and then you can get fatal myocardial depression, where essentially it's very difficult to even stretch your heart that much to produce the adequate amount of stroke volume. You do see a tailing off here, but that's not seen in real life, but you may see this on a curve. Yeah, any questions so far? Oh, I see something in the chat. Clinically, how do we determine CA and CV for the Fick principle? So because it's concentration, you might see it as like the partial pressure in the arterial end and the venal end. So you might see something like P little a O2 equals, and they'll give you a number, And the same thing for the venous end. So PV, O2, and a number. So then you can just take the difference between those two, and it should give you the answer. But good question. So again, moving on to the pathology. So what happens in certain conditions as a result of your Frank-Starling law? So if we take hypovolemic shock into consideration, this is where you've got less circulating volume as a result of something like sepsis, which is like an enhanced immune reaction to an infection. You can get an anaphylaxis or a hemorrhage even, because now you're losing your blood, so reduced volume. So now you're returning less blood to the heart, so reduced venous return, hence reduced cardiac output. This means if you have a reduced cardiac output, you're going to have less blood going into the circulation again. So that's going to drop your blood pressure even more. So it's now becoming a vicious cycle. And this is all due to Frank-Starling law. So independently of neural and hormonal input, this could be perpetuating whatever was causing the hypovolemic shock. Another thing that we look at clinically is lying to standing blood pressure. So you take a blood pressure recording when you're lying down, and then you stand up and your blood pressure will change. And we use this often to measure like how well someone's heart is doing and how well it's being regulated. So when you're standing up, all your blood will pool in your legs. Okay. So then now you're getting less venous return to your heart because everything's kind of stuck in the legs. So you get reduced cardiac output. But in healthy individuals, your sympathetic nervous system will try and correct this so that you can restore your cardiac output, because otherwise, every time you're standing, you're going to faint. So the sympathetic nervous system will kick in. But as you get older, the sympathetic nervous system works less well. And so it's very common that in elderly patients, you see them, fainting and falling as a result of just standing up and their blood pressure dropping quite significantly. So this is the mechanism behind that sort of pathology. And these are the factors that we already talked about. So I thought this is a good summary to include for revision. And the slides will be provided, so you can come back to this. Now talking about afterload, because we talked about preload. Now afterload is the pressure that the ventricles are trying to force their contraction against. So if you increase your afterload, you're putting more work for the ventricles to contract. And so now you're going to reduce your stroke volume because there's a force there. Okay. So some things that can increase your afterload is so if it's pulmonary circulation, any edema there or anything wrong with your lungs can increase it. Or if you've got like edema in your peripheral circulation, that can also put more pressure on the heart itself. So heart failure can actually perpetuate that. Looking at the regulation of your cardiac output so main thing is sympathetic nervous system. And it's always important to know the dominant receptor that's involved. So in this case is the beta-1 receptor. I remember this as beta because it's the sympathetic, but 1 because you've got one heart, whereas 2, you've got 2 lungs. Okay. And noradrenaline will act on these receptors, go via this pathway, which you should have learnt in your pharmacology side of the heart, to then, because if you have increased sodium and calcium, you're going to have greater depolarization and greater contraction. Okay, so that will increase your heart rate. And remember, cardiac output is your heart rate and your stroke volume. So if your stroke volume is struggling, as we said with standing up, then your heart rate will now increase proportionally to match the cardiac output. Noradrenaline can also act on a pathway that involves protein kinase activation, and this will phosphorylate your channels, such as the calcium channel, to open it more often or more frequently on a great amount, and that will increase the amount of calcium inside your cardiac myocytes, and again, increasing contractility. It can also exit from the sarcoplasmic reticulum, so increasing intracellular calcium more, and also greater reuptake at the end of an action potential. So overall, increased contractility. Parasympathetic, remember this is the rest and digest system. So the dominant receptor here is the muscarinic type 2 receptors, where acetylcholine is going to act. And with your rest and digest side, you want the heart to relax. And so you wanted to go into repolarization a lot faster or last there for a longer time to slow down the heart rate. So this time you've got the potassium channels opening. That causes hyperpolarization, so you get reduced frequency of action potentials, and so reduced heart rate. And now, if your stroke volume is going haywire, your heart rate will slow down to match or level out your cardiac output. And two words that often gets mixed up is inotropy and chronotropy. I remember it as the opposite way around. So C for not contractility is actually heart rate. Okay. H and R are next to each other in chronotropy, so heart rate, and inotropy is contractility. Okay, so this diagram summarizes all the different components we've been talking about so far that affect your heart rate and your stroke volume, and hence your cardiac output. Okay, so let's do some Socrative questions. I will have to skip through. Just bear with me there. Okay, so you should be able to see the first question there, where you've got a graph and it's asking you to identify the section where you've got isovolumetric relaxation. Let's have a go at that question. If you can't see the question, just let me know. It might be bugging on that end. For the Socrative, yes. Just bear with me, I'm trying to... So if you go to that link and type in OSMI cardiac, it should come up. Okay, just because I'm conscious of time, I will move on from the first question. So yes, everyone got that correct. It was E, because that's the phase where you've got your heart is staying the same volume, as the volume of blood in the heart is the same, but your heart is relaxing, so it's called isovolumetric relaxation. Good. Next question is looking for atrial contraction. Couple more seconds. Okay, perfect. Yeah, so that's A, because that little bump in the curve is representing your atrial contraction. How about the QRS complex? Which part does that coincide with? Okay, yep, perfect. This is B, because that's your ventricular contraction, so your pressure is going sky high, and so that's your QRS complex. What about the rapid ventricular filling phase? Few more seconds. Okay. Okay, so we got a split here. So the correct answer was F. And the reason is because when your heart is relaxing, and this is the point where you've got filling of your ventricles. So remember, after E, because I know someone put E, E is when your ventricles are relaxing after contracting, okay? When your ventricles relax, the next phase is your atrial contraction or atrial filling. When your atria fill to a certain point, the valves will then open and allow blood to trickle into the ventricles. And so that point is your is F, where your ventricles are slowly filling, or rapidly filling in this case, because once your atria is filling with blood, because that's atrial relaxation as well, that blood will trickle in through your ventricles. Okay. You can also work it out by process of elimination. So we know it's not B because B is your ventricle contraction. C is kind of, you can see the pressure is now tipping over and going into relaxation. So it can't be that phase. D is also part of C, so we know it's not there. And E, we said it's the ventricles are relaxing because they're getting ready. Well, they don't have any blood in them, so they're relaxing, ready for the next phase of the contraction. Okay. And last question for this section, which part includes the second heart sound? Okay. So most of you got it correct. It was E. Good. So the second heart sound, remember, it's coinciding with your aortic valve closure. So we want to find a point where so aortic valve closing means that your ventricular pressure is less than the aortic pressure. And that would be where your ventricles are now relaxing, okay? Because the blood is now being ejected into your aorta. So the pressure in your ventricles will fall and your ventricles will start to relax. So that should be point E, okay? All right, so we'll stop those questions there and we'll move on to blood pressure because that was the next most requested topic. So how we measure blood pressure is with the blood pressure cuff. You can do it like with your manual one or the automatic one, but essentially how we measure it and how it is measured is we listen to the flow of blood in the arm, and we're trying to see at what point or what pressure value do the sounds, which are called Korotkov sounds, disappear, okay, or reappear, okay. These sounds are produced when you've got the flow of blood going through the vessel. So if you occlude the vessel, you won't hear it, and when you reopen the vessel, you should hear it. Okay, so you can see here the black line represents the pressure of the cuff. Okay, so it's slowly, you pump it up to above systolic pressure, so often above 120, and we slowly release the cuff pressure until we start hearing Korotkov sounds, because at this point, the cuff pressure is greater than your blood pressure. So we're essentially occluding the vessel, and so there's no blood flow. But as you decrease the pressure, eventually it reaches a point where you're now at your systolic pressure. So there should be some sound coming through, or some flow through the vessel, so you should hear Korotkov sounds. And again, you keep decreasing the pressure of the cuff until you don't hear Korotkov sounds anymore, because at this point, the pressure of your cuff is lower than your blood pressure, and so now there's no sort of force acting on the vessel to occlude it and keep it, from collapsing and opening, collapsing and opening. That is your Korotkov sound. Okay, so normal blood pressure is 120/80, and it's measured in millimeters mercury. Pulse pressure is different because it's the difference between your systolic blood pressure and your diastolic blood pressure. So this person's pulse pressure would be about 40 because you're subtracting these two. And Also, don't confuse it with mean arterial pressure because it's not just an average or arithmetic average. You actually have to work out a third of your systolic and add it to 2/3 of diastolic. The reason we do this sort of proportion is because you're spending more time in diastole rather than systole. So these fractions kind of represent that weighting in time. Okay. And so this is now incorporating mean arterial pressure into cardiac output as well. You also are concerned about your total peripheral resistance. So we'll now talk on what are the different properties of the circulation and how that can affect your cardiac output. This is just another equation linking mean arterial pressure to cardiac output with your central venous pressure and your SVR. Okay, so it depends on what elements of the question they give you. So if they give you mean arterial pressure but not total peripheral resistance, then you can use systemic vascular resistance as well. So let's start off with Ohm's law, because this is essentially the fundamental aspect of vessels. There is flow of blood. So Q in this equation represents the flow of blood, whereas I don't know what you call this, but change in P is your change in pressure and R is your resistance. Okay, so this is your vessel and you've got a flow of blood through the vessel. That flow is going to be directly proportional to the pressure gradient. So the change or difference in pressure from your arterial end to your venial end. But it's also indirectly proportional to resistance. So if you have higher resistance, you'll have less flow because now you've got a force acting on those vessels to occlude that flow. You've also got pressure from the ventricular contraction, and that's called hydrostatic pressure. It's the pressure of the blood itself in the circulation. And the gradient that we're creating is between that hydrostatic pressure and your central venous pressure that we talked about earlier on. Okay, and so resistance is a property of the vasculature itself. It will be different from your aorta compared to your capillaries, for example. So we need to also take that into account when talking about flow and blood pressure. So Poiseuille's law gave us the factors that influence your peripheral resistance, and the main ones being your length of the vessel. So the longer the vessel, the greater the resistance. The viscosity of the blood itself inside the vessel, and also your radius of the vessel. Okay. So because the radius is on the denominator of this equation, the greater the radius, the less you have of resistance, and vice versa, okay? And radius actually has the biggest impact here because it's to the power of 4. So that's why radius of the vessel is really important when you're talking about resistance. Now, Laplace's law follows on from Poiseuille's law because they describe the factors that influence the radius of the vessel, particularly the tension in the wall and the pressure of the blood itself. So if you've got a smaller vessel, then your pressure will be larger on the actual blood, okay? So this is the equation. This is your radius, this is your tension, and this is the difference in pressure between the inside of the vessel versus the outside of the vessel. So you can see the smaller the vessel, the radius, then to get a small radius, you want a small tension, but a large difference in pressure. Okay, so that's why there'll be a larger pressure that you can be applying on the blood itself. Hence why when you've got tiny capillaries, they can actually withstand much greater pressure than your larger vessels because of their tiny radius. Okay, so it's all about the properties of the vessels and how much they can withstand low pressures, high pressures, and so on. Okay, Now, I know there's loads of laws that you need to remember, and it can be confusing with the equations, but this slide, if you take anything away, it should be this. Pressure is proportional to resistance, okay? So the greater the resistance, the greater the pressure you're going to be having. But then resistance is inversely proportional to radius. So the smaller the radius, the greater the resistance. Hence why capillaries are really good for that. And your radius itself is proportional to the tension in the vessel wall. So greater the tension, the greater it's actually squeezing in or tightening that lumen of the capillary or vessel. So your radius is going to be smaller as well. Now, if we say there's, if we're trying to change the wall tension, that's going to impact your radius, okay, according to Laplace's law. That radius will change your resistance, okay, according to this. And that resistance will impact your pressure of blood, and that will impact your ultimately impact your flow. So this is kind of the train of thought that should be going through your head when they give you something to do with tension, radius, resistance, and so on. Okay. And again, there's regulation of everything. So it's back to the sympathetic nervous system again. Adrenaline and noradrenaline. Remember, they have different affinities for your receptors, but these are the main receptors involved. Note this beta 2 receptor rather than beta 1, because you've got 1 is for the heart, you have one heart, whereas 2 is for your vasculature. So it's beta 2 receptors, and they will cause vasoconstriction or vasodilatation depending on which receptor they're acting on. You've also got autoregulation. So this is kind of the local control of blood flow, where when your arterial pressure of your blood is increasing, you'll get more flow to the tissues itself locally, even though your systemic control will be kind of baseline, you'll be there. And if your local blood flow is increased, then it will also rapidly decrease back to normal, so that when you exit the circulation locally, it should be back to its normal flow. Main thing to note is that you've got, in the background, you've got global sympathetic control that we just talked about. These two are acting locally at the tissue or wherever it's acting. Okay, so it's on top of that global sympathetic control. So the two types we've got is metabolic and myogenic. Let's start off with metabolic. So this is where you've got different chemicals in your in the circulation or in the surrounding tissue that is impacting how much flow you're getting to the tissues. So some substances like adenosine, carbon dioxide, protons, they have a vasodilatory effect. So the more of those components you have, the more your blood vessels will vasodilate. And this is because, for example, if you have carbon dioxide, that's signaling to your body that you've not got enough oxygen in the system. And so by vasodilating, you're sending more blood, oxygenated blood, to the tissue to overcome these carbon dioxide. Okay. You can get active hyperemia, which is essentially where hyperemia means more blood flow to that region, which is determined by your metabolic activity. So again, linking back to your CO2 levels, let's say you have less oxygen delivery, you're going to be producing more carbon dioxide, but also some more potassium as a result, and you get vasodilatation to correct that. So you're sending more oxygenated blood to those tissues. The opposite is true if you have lots of oxygen and less CO2, because now you don't need to send as much blood to that region, but you might need more blood to another region. So it's shunting the blood away from areas that are well perfused and then directing that blood to areas that are less well perfused. Now, reactive hyperemia is when you've got a change in your oxygen and carbon dioxide levels, which is caused by the temporarily interrupted blood flow. So it's not blood flow causing, sorry, it's not metabolic changes causing changes in blood flow, it's the other way around. It's the changes in blood flow that is impacting the amount of O2 and CO2 in the system. Okay, so that is reactive hyperemia. The blood flow is changing as a result of whatever happened from the interrupted blood flow is reacting. And these are the pathways that are involved for nitric oxide. So this is also another vasodilator because it acts through enos to stimulate guanylyl cyclase, and that will stimulate your cyclic GTP to cyclic GMP and your protease kinase G, and that's going to phosphorylate various proteins to allow vasodilatation of your blood vessels. Looking at the myogenic response, so this is moving away from metabolic, this is how your muscles are working in response to a change in blood pressure. Main one is your baroreceptors. So the two baroreceptors are the carotid sinus baroreceptor and the aortic arch baroreceptor. These are linked to your glossopharyngeal nerve and your vagus nerve. Okay, so these are the cranial nerves, and those will synapse into the nucleus tractus solitarius. Okay, it's very important you remember this because you can get questioned on it. That will then be sending signals to the medulla, where essentially if you've got a greater blood pressure in the system, that will cause the receptors to fire more frequently. That will tone down the sympathetic regulation, and it will now increase your parasympathetic innervation. So it's telling the system, calm down, your blood pressure is high, go into rest and digest mode because it doesn't need to be that high. Okay, so it's almost like a negative feedback loop here. And you can say the same thing the other way around. So what happens when your blood pressure falls? So a good way might be to draw a diagram showing the synapse of these two baroreceptors to the nucleus tractus solitarius, to the medulla, and what happens as a result. Okay, so that was all the stuff on kind of controlling blood pressure. We're almost there with the hemodynamic stuff because now we'll look at tissue fluid because that's also impacted by hydrostatic pressure as a result of blood flow. So Starling forces is these four forces, looking at your hydrostatic pressure and your oncotic pressure, both within and outside your capillaries. Okay, you've got the arterial end and your venous end. So the hydrostatic pressure, it will be greater at your arterial end as a result of just being closer to the heart, essentially. So the pumping of blood will increase the hydrostatic pressure there, but by the time it goes to the venous end, it will lower. Your oncotic pressure is determined by the amount of proteins you have in the blood vessel itself. Okay, so the more protein content, the greater the oncotic pressure. So at the arterial end, because of the high hydrostatic pressure, the overall amount of filtration of your fluid out of your capillaries will be greater than it will be in the venous end because of the lower pressure. And so at the venous end, you'll have reabsorption of fluid containing your waste materials, whereas at the arterial end, you'll be pushing out all the nutrients and the fluid that the tissues need. Okay. So this is a lot of information here, but essentially all you need to know is that the pressures basically depend on how much, as I said, how much blood you've got in the system and also how much protein in the system. If you have excess fluid, which you can do, that fluid will be draining back through the lymphatic vessels because obviously you don't want the fluid just leaking around in your tissues. You need to recycle it somehow. If you have a problem in your lymphatic vessels, then that can lead to something called lymphedema, where you've got excess fluid in the lymphatic system. Okay, this can happen as a result of things like surgery to lymph nodes. So if someone has metastatic cancer to their lymph nodes, they might have lymph nodes removed and they'll have lymphedema as a result. So you can also get peripheral edema where there's a imbalance in your tissue fluid clearance. Okay, so this is something called pitting edema because you get pitting when you press in the legs or the arms that are swollen. Okay, these are three conditions that I would say are common that cause peripheral edema. So if you see one of these conditions in your MCQs, then think, okay, maybe edema could be related. Heart failure causes peripheral edema because your blood is staying where it is in the venous system, and so it starts to pool in those tissues, okay? So if you're pooling the blood in those areas, you're going to raise the hydrostatic pressure result of the blood there, and that's what's causing the fluid to leak out of your arterioles to the surrounding tissue fluid, surrounding tissues. In liver failure, the liver is important in making something called albumin or plasma proteins. So if you have liver failure, the liver can't produce those proteins anymore. And so you get a result, as a result, you get a reduced oncotic pressure. Okay. And the reduced oncotic pressure means that you can't reabsorb as much fluid as possible. And finally, the thing that I mentioned with obstruction or insufficiency of the lymphatic system as a result of removal, for example. So now you just don't have enough lymph vessels available to drain that fluid. Okay, so let's do some questions. Should be the next one. So in a subject with a pressure cuff placed correctly around their arm, Korotkoff sounds are heard in the following circumstances. So which of these is the correct answer? Okay, and the answer, yeah, all of you got it correct. So it's when the cuff pressure is between your systolic and diastolic pressure. Good. Next one, which statement concerning mean arterial blood pressure is false? Okay, and so, yeah, the correct answer was that the mean arterial blood pressure is not the arithmetic average of the systolic and diastolic pressures, because remember, you spend longer in diastole than systole. Someone else put that mean arterial blood pressure is expected to fall in response to activation of the baroreflex by baroreceptors. That's not necessarily true because essentially you should get an equivalent reduction in your systolic and diastolic pressures. So let's say both of them fall by 30, the gap between them, because that's your, sorry, the mean arterial blood pressure should be the same because there's the same proportion of both that's still being calculated. Okay. Good. I think there's a question in the chat says some sources say that vasoconstriction increases venous return to the heart, whereas others say increased TPR decreases venous return. Increased total peripheral resistance decreases. Right. Okay. By sources, do you mean like textbooks or like studies? Because I think it could be different depending on what factors they're looking at. But if you think about it kind of systematically, when you've got more venous constriction, sorry, when you've got more constriction of your blood vessels, you are reducing the blood flow, okay? And so now you have less blood returning to the heart, okay? But also if you're, I think that makes sense, right? So you increase the resistance, that will reduce your flow because you're collapsing the vessel more. So if you got reduced flow, you get reduced venous return. But if you're thinking about pressure, if you increase the amount of, so if you think about capillaries, for example, if you increase the resistance, you're putting more pressure on that vessel, and then you get increased pressure back to the heart, so increased venous return that way. It's like redirecting blood flow. So I think the reason it's confusing is because it depends on which part of the circulation you're looking at. If you're constricting areas that don't need the blood flow and you redirect all of that blood flow to another region, then you could be increasing venous return that way. So for example, if the blood is pooling in your legs, people tell you to kind of stand on your tiptoes, and that is helping return the blood flow back to your heart because you're almost constricting the vessels with your muscle action. So it depends on which part of the circulation you're talking about and where that blood is directed to. I hope that makes sense. Okay, we've only got a few minutes left of the session, and I know that we haven't covered everything. So would people prefer to go through the content or do some questions? Because I've got quite a few questions on Socrative. You can unmute or you can pop it in the chat, what you prefer. More questions? If there's no one who would like to disagree, then I'm happy to go with questions. So I'll go back to the start because I know we didn't do the electrical activity questions. Okay, so you should be able to see that question there. It asks, which statement about ventricular membrane potential is true? Okay, so the correct answer was A. In a beating heart, circulating adrenaline will shorten the action potential. One person put ventricular action potential typically overshoots the Nernst potential for sodium, which is not true because the Nernst potential is kind of the resting potential, so it wouldn't be overshooting that for the ventricular action potential. I don't think anyone else put the other ones, so that should be fine. And the next question, which statement concerning the ECG is correct? Okay, so the correct answer here was T wave should come before the second heart sound. Because remember, the second heart sound is your aortic valve closing, and that's because your ventricles are relaxed now, so the pressure is dropped. So the ventricle relaxation phase is your T wave repolarization. So that should come before. QT interval directly proportional to heart rate. Not necessarily. The heart rate is determined by the RR interval, so how long the gap between each heartbeat is, and that's proportional to a heart rate. First heart sound occurs at about same time as the peak of the P wave. Not really. So if I go back to, let's find this slide. So if we go back here, you can see that the P wave is actually all the way here. The first heart sound only occurs when your mitral valve closes, and that's when your ventricles squeeze, contract, and the pressure of the ventricle is greater than the atria. So that shuts your mitral or atrioventricular valve. So P wave is actually your atrial contraction. It shouldn't be affecting, it shouldn't be related to the first heart sound. Okay. Next one, so we've got an ECG trace here, okay, from lead 2. Considering the frequency of P waves and the frequency of QRS complexes, which of the following conditions is shown? You can press the picture to make it bigger if it's hard to see. Okay, for the sake of time, I will carry on. So this is actually third degree or complete heart block. So how we can work this out, I think this flow chart that I made here helps actually to determine which one. So the examples given here are types of AV or atrioventricular heart blocks where the conduction of your from the SAN node is not passing over to the AVN node. So that's why you get a block between the atrium ventricles. So always start by looking at your PR interval. If it's prolonged, then we know it's AV block because that conduction is not passing through as properly. If you've got a constantly prolonged PR interval, as in, let's say it's, I don't know, 5 small squares every time, that's constantly prolonged, okay? Then look at whether all of your P waves are followed by a QRS, because that's suggesting, okay, it's conducting, the P wave is, the atrial contraction is conducting to the ventricles, it's just that the PR interval is prolonged. If that is the case, you've got a P wave followed by QRS every time. That is first degree heart block. Okay, so that's your basic heart block, let's say. If you find that you've got absent QRS complexes, so here, I don't know how well you can see this, but you've got P, QRS, T, P, blank, P again, QRS, T, P, QRS, T, P, QRS, T. So here, you've got an absent QRS complex. The P wave has not fully conducted through to produce your ventricular contraction. This is known as second degree Mobitz type 2, okay? But you've got, remember, it's got constant PR interval. Moving on to the ones where you've got irregular PR interval, so one of them might be longer or shorter than the previous one. Again, looking at whether you've got absent QRS complexes or whether they're not associated at all with your P waves. So looking at your absent QRS, so this is when your P waves are there and your QRS are there, okay? It's different to first degree because your PR interval is not constant. So it might be 3 small squares, 4 small squares, 5 small squares, and so on. It gets longer and longer until eventually your QRS complex drops, it disappears, and then it will restart the cycle. Short PR interval, medium PR interval, long PR interval, drop, okay? That is second degree type 1. Maybe it's type 1. Third degree is like the extreme of the spectrum. Nothing is working together. So your your P waves is doing its thing, your QRS is doing its thing, but they're not working together. hence why you see some of these funny looking almost T waves here, because your P wave is actually merging with that T wave. And so it looks very funny. You've got two waves next to each other. So if you were to look at your P waves, they will be constant. And your QRS complexes will be constant. But everything else in between does not synchronize with each other. It doesn't look as nice as these traces, for example. And so that is complete heart block or third degree heart block. So in this example, in this question, the PR interval, we know it's prolonged, okay? We also can see there's no constantly prolonged PR interval. It gets, so at the start it's long, then it's short, then it's long again. So, it's doing funny things here. So we know it's irregular. And then looking at whether we've got absent QRSs, where you've got constant ones and then it drops, or is it just not associated with each other? And a good way to tell is that funny little bump in the T wave. And you can see that in the 1, 2, 3, fourth complex, that you've got those two little McDonald's shaped signs on there. Okay, so that is the third degree complete heart block. Okay. I'm aware we've got another session after this with another group, so I won't overrun. If anyone does have any questions, you can email me, and I can also send you a copy of the remaining questions if you'd like them. But just before you go, please do fill in the feedback form to get a copy of the slides and the recording. I'll also put in the link on the chat if anyone can't access the QR code. But thank you so much for joining today and hope you found it useful. No worries. I've also put the link in the chat if you can't scan the QR code. Yes, I'll put that in the chat. There you go. No worries. All the best with exams. Hi, sorry, is that okay? And
Hiya.
hiya. Was that okay? And am I
Yeah.
do I just
No,
leave?
it was really good. Thank you so much. I will send you the feedback
Perfect.
once the people have feedback. The only issue with that is we use the same form for everybody's feedback, so I cannot like directly give you the link to it,
Oh,
but
okay.
I will just copy out your component of the form and I will send it to you if you're interested. But thank you so much. I think it was really useful.
Thank you.
And people seemed happy.
Great, thank you.
Thank you. Have a good evening.
And you. Bye-bye.
Bye bye.